Then the ligaments of the lumbar spine. So here in this model, you can see three strong ligamentous structures that hold the spine together. So this is the ALL. So ALL is a very broad sheet of connective tissue that runs in front of the spine. It's very, very large. You can see how big it is. And on the back of the vertebral body, there is a narrower sheet of ligament that's called the posterior longitudinal ligament. And that's how it looks. And you can see the posterior longitudinal ligament here. It covers the middle part of the disc, and that's how it reinforces the annulus of the disc here. And that's the reason why the disc herniations are more common in the posterolateral area. So that's why you will find posterolateral disc herniations to be more common than something bang in the center, because the PLL reinforces that annulus and acts as like a barrier for disc herniations to happen. Although you do see disc herniations in the center, but they are more common in the posterolateral region. And then there is a very strong fibrocartilaginous structure between the two vertebrae. As we all know, that is called the intervertebral disc. And the intervertebral disc is composed of the annulus fibrosus and the nucleus pulposus inside. Okay, so this is how the annulus fibrosus looks. The annulus fibrosus is a tough covering outside, and then there is a soft pulpy thing inside, which acts like a shock absorber. So this is how it looks, and as the disc degenerates, that inner soft part becomes more fibrotic. So these are the ligaments of the lumbar spine. I have isolated them. So just to show you different ligaments and what their importance is. Now, among the ligamentous structures of the lumbar spine that are most important, that hold the spine together, the most important one is the intervertebral disc. So that's the strongest ligamentous structure that holds two vertebrae together. The interspinous ligament and the supraspinous ligaments are not as strong. So the main stabilizing structure of a lumbar motion segment is the intervertebral disc, the orientation of the facet joints, and the facet capsule. So you want to preserve the facetal anatomy and the disc as much as possible to maintain intersegmental stability. So as you may have seen during surgeries, that when we do these surgeries in the lumbar spine, very commonly we'll sacrifice the midline supraspinous and intraspinous ligament when we are doing a laminectomy or interlaminar decompression. But wherever possible, we avoid doing a very complete discectomy or a complete facetectomy. If you do a complete discectomy, invariably you are doing a fusion, a T-lif or a P-lif. And the same goes for the facet joint. If you are removing more than 50% of the facet joint, then invariably you will have to fuse that segment, because you are compromising on the stability of the motion segment. So that's about the ligaments that hold the lumbar spine. So this is another diagram that I want you to remember. It's the unique ligamentous attachment of the L5 vertebral body. So this is the L5 vertebral body, and you can see these very strong ligaments on either side of the L5 vertebra, and this is called as the iliolumbar ligament. Now, iliolumbar ligament is a ligament that connects the L5 transverse process to the ilium, right? This ligament. It's a very strong ligament, and that provides an inherent stability to the L5 vertebral body, especially if it is a deep-seated L5. That means if you see at the highest point of the iliac crest, if you see the L5 way beneath the highest point, you can imagine how strong these ligaments are that hold the L5 together. And that's the reason why L4, L5 spondylolisthesis is more common than L5-S1 spondylolisthesis. So degenerative spondylolisthesis is more common at L4, L5 rather than L5-S1. What is more common at L5-S1 is a lytic spondylolisthesis that we discussed in the first slide. So if you get a stress fracture of the L5 pars, what you will get is a lytic spondylolisthesis or adult ischemic spondylolisthesis. So that is more common because lysis is more common at L5. But if you don't have lysis, because the L5 vertebra is so strongly attached to the pelvis, more motion happens at the L4, L5 level, and that's why the tendency of L4, L5 disc to degenerate is much higher, and that's why you will see degenerative listhesis more common at L5S1. Sorry, L4, L5. So another component of this ligament, if you see from the front, is this part of the ligament. So there is a ligament that goes from the transverse process of L5 to the ala of the sacrum. And there is a component of this ligament that goes from the transverse process of L5 to the ilium. So this is a very strong ligament that holds the L5 on the sacrum. So that's the anatomy of this region. And now when you are doing a spondylolisthesis reduction or a high grade spondylolisthesis reduction, you have to release this ligament if you want to get this L5 translated back onto the sacrum. So all these connections you will have to disconnect.